So, okay, today I want to do something a little different. So, this is the cerebral cortex, okay? And then we have the cerebellum here. When we have the cerebellum here, and we have the midbrain here. Can someone, if you remember, tell me what this structure is? If you remember, can someone tell me what this structure is? Two humps on the midbrain.
The two colliculi.
Yes, it's the superior and the inferior colliculi. Okay. Then we have the pons, the medulla, and then the spinal cord. Okay. So this was one structure I talked about once, but didn't go much into detail. Next, I will talk about the blood supply. So if you remember, I told you the middle cerebral artery will come to the sides, two sides. They will come out of the insula. Okay, this area is called the insula. They will come out of this region and they will supply blood like this. This is how they supply. Okay. And the anterior cerebral artery will be supplying from here. And the posterior cerebral artery will supply the rest here. Okay. Now, can someone tell me what is this area called? The area where I didn't draw the thick blood vessels? Can someone tell me? What do you call the area which is hypoperfused? Because all these big vessels don't go, only small vessels go. So it makes them more likely to be affected during a stroke. Can someone call this area a name? What is this called? Guys, it's called the watershed area, okay? These are the watershed areas of the brain. And if there is a situation where the patient doesn't get enough oxygen to the whole body, let's say he's in shock. So the watershed area is most likely going to be affected, okay? And in this area, you have the hippocampus. Remember, it's a structure of the middle cerebral, it's in the temporal lobe, the hippocampus. So usually it's the hippocampus that's going to be affected first, okay? And next, I need to remind you guys this, the localization of these regions. Can someone tell me, okay, let me draw another diagram. So I'm just going to draw that same image without the blood vessels, okay? So this is the region which is supplied by the MCA, okay? Here is the primary motor, the sulcus, okay? Primary motor sulcus, and we have our homunculus here, okay? Can someone tell me which, if there is a stroke of the MCA, which area of the body is going to be affected? Which areas? Can someone tell me that?
The upper body.
Yeah, the upper body, including the arms upwards, okay? And can someone tell me what area is going to be affected if the anterior cerebral artery is damaged?
Lower.
Lower. Okay. Now today, for the language, we are going to learn something called Broca's area and the Wernicke's area. Okay. What I need you to know, can someone tell me, is the Broca's area in the motor cortex, that means past this point, or is it here in the sensory cortex? Can someone tell me where the Broca's area is? Is it here or?
The motor, in the motor.
Yeah, so it's B. This is where you get the Broca's area. Okay. And over here is where you have the, what's this?
Wernicke's.
Sorry?
Wernicke's.
Yes, this is where you get the Wernicke's area. So this is all stroke knowledge. You can see if there's any damage to the arteries that supply these, you can have different problems. Now let me be a bit more specific. If there is a damage to an artery which goes like this, it is most likely the person will have symptoms of the upper body plus speech difficulties. Do you understand that? The Broca's area is a motor area. Okay, that means it involves in producing speech. I'm just building up on the stroke lecture right now. Okay, we are going to come to this in the language lecture, but I just want to give you an introduction. Do you understand this? If there is damage to an artery which supplies this area, you can get MCA branch which supplies this area. You can get damage to the Broca's area and the upper body. Okay. I hope you guys understand this. Now, today we are going to discuss the hypothalamus. And I'm going to touch a bit of endocrinology for this. Okay. So first of all, the location of the hypothalamus. I have drawn this image around 5 to 6 times, but I keep drawing it because it's important. These are the areas in which CSF travels. Can someone tell me what this enlarged area is called?
Fourth ventricle.
Yes. And what is this area?
Sylvia.
Cerebral aqueduct
Aqueduct.
of Sylvius. Okay, cerebral aqueduct of Sylvius. I have done these, so I won't be labeling these. Next, we have, what is this structure?
Third ventricle.
Third ventricle. Okay. And adjacent to the third ventricle, a bit superiorly, we have two structures that has a Y-shaped gray matter lamina region in the middle. What is that called?
Thalamus.
Yes, thalamus. Okay. And then we have a very thick sheet of white matter. Okay, it is a thick bundle of white matter. What is this called? Sorry? Internal capsule. What is this nucleus called? This nucleus in general, what is the name? It looks like a lens. So
Lentiform.
yes. What is the medial area called? What is the medial area called? This is the lentiform nucleus. And what is the medial area? Yes, globus pallidus. And it is divided into the medial aspect and the lateral aspect. That is important for Parkinson's disease. Okay. So that these are structures of the basal ganglia. And what is this area called? Begins with a P.
Putamen.
Yes. Okay. Now, let me teach you how this hypothalamus is divided. Now, okay, let me conclude this diagram first. So, you know, there are two nuclei here. What are those nuclei called? Which one connects to the visual system, one connects to the auditory system.
Lateral and medial geniculate nucleus.
Yes, and the medial and the lateral geniculate bodies in nuclei. So over here we have the optic tract. And this area is called what? The place where the optic nerve goes to the opposite sides. What is this area called? Sorry?
The chiasma.
Yes, optic chiasma. Okay. And then this area is the hypothalamus. You guys know that. There are two structures like this, which is a part of the limbic system. What are these pathways called? What are these two bodies called?
Mammillary bodies.
Yes. And we have the pituitary here. Okay. So I hope you guys remember this, because this is the most basics that you will need to understand today's lecture. Now let's go into a bit more detail of how the hypothalamus divides. Okay. So first of all, I hope you guys remember that there was a caudate nucleus which went above like this and ended up at the amygdala. Don't draw this. Do you remember this? And from there we have the hippocampus, which comes above as the fornix and goes and penetrates the hypothalamus. It penetrates the hypothalamus and then it sends fibers to the mammillary bodies. I hope you guys remember that. We are going to draw this again. Do you remember this? If not, you can ask me and I will go into a bit more detail there. That is a part of the limbic system. Okay. Now I'm going to draw it again in more detail, because this structure, which is called the fornix, is what divides the hypothalamus into functional areas. Okay. Now I hope you guys realize that the fornix is on both sides. It's not just on one side. Comes from both sides. Okay. So there are two fornix, and let's now draw the hypothalamus. So this is what it will look like if you look at it from above. It's very simple. It's just a box, and in the middle you will have the third ventricle. Third ventricle. Now the fornix will come from above and penetrate here. Comes from above like this and penetrates here, and it sends fibers to the mammillary bodies. Okay. Okay, let me draw it as a circle. I hope you guys know that the mammillary body is below. So I'm going to draw dotted lines to show the fibers going there. So the fibers will enter the mammillary bodies. Okay. Same situation on the other side. We have this coming in like this and piercing the hypothalamus and sending fibers to the mammillary bodies. Okay. Now, what is important is the fornix is what divides the hypothalamus into 4 regions. Let me just extend the third ventricle like this. Let me just, okay. Now you can see this area so it's best if you can highlight it, but basically you can see that the fornix will divide the hypothalamus like this. Okay. So you have 4 functional areas on the left and the right side. Let's see. Can someone name this part? Can someone name this? What is this part called? Okay, we are looking at the left hypothalamus, left side of the hypothalamus, and it is the lateral aspect, left lateral hypothalamus. Okay, so that means this is the left medial hypothalamus. Okay, the left medial hypothalamus. Same here, right medial hypothalamus and right lateral hypothalamus. And can someone tell me what is the structure over here? What is this structure which is going right in front of this? Guys, please turn on your cameras. I cannot see a single camera on. Only a very few are on. Can someone label this structure? What is this structure called? The place where the optic nerve bifurcates? Optic chiasma.
Optic chiasma.
Do not forget this, because any tumor that grows anywhere in this system will go and compress this. Okay, so you will have eye defects if there are tumors of the it's mainly the pituitary. So let's now show the other aspects. Now this is the mammillary body which I drew, and sorry, give me a second. Yeah. Wait, give me a second. Okay. We are looking at the section below this, okay? So I will just label some parts. This is the mammillary body. This is called the tuber cinerum. Okay, the part in which the hypothalamus begins the pituitary gland. Okay, and this is called the medial swelling. And then you have the infundibulum. And you have the posterior pituitary. And over here we have the anterior pituitary. Now, I'm going to go into a little bit of detail about the pituitary because there's a tumor of the pituitary we need to discuss. So the hypothalamus has a very intimate function with the endocrine system, okay, with the pituitary gland. Can someone tell me, okay. So the posterior pituitary is a derivative of the neuroectoderm. Okay, it derives from the neuroectoderm, while this, the anterior pituitary, comes as a mass of cells from something called the Rathke's pouch. This is the primordial, okay, not primordial, but in the fetus, your pharynx develops, and there's a pouch called the Rathke, R-A-T-H-K-E pouch. Okay, the Rathke's pouch is what comes here as the anterior pituitary. Okay. Now, if I was to ask you guys a question, just based on this, can you guys tell me? So the posterior pituitary has another name. It is called. Is it called neurohypophysis or adenohypophysis? Can you guys tell me?
Neurohypophysis.
Yes. And the reason for that is there are there are nerves. So there are nerves. Here is the cell body of the nerve, and here's the axon, and here is its terminal. Okay. There are nerves which go here like this. What are the two hormones that are produced in the Okay, this is not from the medial body, it's from the hypothalamus. What are the two hormones that are produced by the hypothalamus and released from the posterior pituitary? Here are the blood vessels. What are the two hormones? Come on, guys. This is basic endocrine knowledge. There are two hormones produced by the hypothalamus, released by the posterior pituitary. Can someone tell me those two hormones? It's very simple. Yes.
LSH.
Yes. No,
LSH.
it's oxytocin, and ADH. Okay. These are the two hormones that are produced in the hypothalamus. Remember, this is a neuron. Okay. And I will give you guys another helpful thing. It is produced in the cell body. Okay. Here's the nucleus, and it is produced in the cell body. It travels along the axon and goes to the synapse, and it will be present as vesicles. Okay. Now, can someone tell me, based on what I just said, are these hormones protein hormones? Are they peptide hormones, or are they lipid hormones? Based on what I just said, protein hormones or peptide hormones or lipid hormones?
Lipid hormones.
These are protein. These are peptide hormones, because the nucleus is the cell body, right? Is in the cell body. That causes production of proteins, and those proteins are what is transported in vesicles to be released from the posterior pituitary. Remember that. Okay. That's just a helpful hint if you are learning biochemistry. Now, the anterior pituitary has a relationship that includes blood vessels. Okay. So there are neurons. Okay, let me use a different color. There are neurons which synthesize substances, hormones, and they release it into this capillary bed. And they will travel and form a second capillary bed What type of blood supply is this? What is the name for a supply which has two capillary systems? What do you call a capillary system which has two? Okay, what do you call a blood supply which has two capillary systems before it joins a venule? Let me give you a hint. The liver also has a similar supply like this. This is called a portal system. Okay. And remember, from you have to understand.
Peritubular network.
Yeah, it's the peritubular capillary network. It's a portal network. Remember this: the hormones that are produced by these cells here, they will go and act on the cells here. Okay. So the hormones that are produced in the that travels to the anterior pituitary, they will work on the cells of the anterior pituitary. Okay. And let me just tell you guys one more thing, because that will come later. There are two types of cells. There are basophilic cells and acidophilic cells. Acidophilic cells produce two hormones, prolactin and growth hormone. Okay. The acidophilic cells produce two hormones, prolactin and growth hormone. The FSH, LH, though the other stuff, they are produced in this basic area. Okay. This is important because there's a tumor of the pituitary gland which causes overproduction of these two. It's an acidophilic tumor. Okay, I discussed it in one diagram. So next, let's go to the nuclei of. Okay, one thing. This is a very important hint. It's a very important point for MCQ in histology. Okay. If you get any histology questions for your final exams or whatever, this can be part of it. Okay. Now, let's go into the nuclei of the hypothalamus. I'm going to look at just one side. Okay. I'm going to look at the right side only. Okay. It has the medial hypothalamus and the lateral hypothalamus. Now look at this table. I have drawn it as follows because, okay, so sorry, we are looking at the left one. We are looking at the left one because this is going to be the lateral aspect. The left lateral hypothalamic nuclei are going to be here. And then here's the medial aspect. Now, before I go into this, I need to tell you guys how these names came. It's not hard. Okay. It's basically this area. Okay. Let me just draw the hypothalamus again so you won't get confused. Okay. Guys, sorry for that. Make it a big area like this. So this area, it's basically, this is the mammillary area. So we have the lateral and the medial aspects. Okay. Then we have the tuberous area. Tuberous. Remember, it's part of the, here you can see, it's called the tuber cinerum. Okay. That area, the nuclei from that area, which in this area are called the, I will draw them here. Okay. And then we have supraoptic, that is in this area, and the preoptic, it is this area because it is just before the optic chiasma. Okay. Supraoptic, that region is a bit superior to the optic chiasma. That's why you call that area supraoptic area. Okay. I hope you guys understand this. If you don't, you can unmute and ask me right now because we are going to go into the nuclei. Basically, the functions of the hypothalamus we are going to discuss. Okay. So let me just clarify one more time. The hypothalamus is divided into 4 areas by the fornix and the third ventricle. So what we are looking at right now is this. Okay, we are going to look at this section. Okay, here you have the mammillary area. Here you have the tuberal area. Here you have the supraoptic, and here we have the preoptic. Okay, optic because of the suprachiasmatic nucleus which goes here. I hope you guys understand this. So now let's look at the lateral. Let's look at this region, the lateral tubular region. We are going to look at this first. Okay. Now, the nucleus here has a function related to hunger and thirst plus your anger. Okay. When you're hungry, you get angry. Okay. That nucleus is here. This, just draw it like this. Okay. This is the hunger controlling center. It tells you that you're hungry. Oh, see, I drew the eyes like that to show that he's angry. And also hunger and thirst. This nucleus is involved in hunger and thirst, and it is called the lateral hypothalamic nucleus. So what happens is when the patient, okay, when you or anyone is hypoglycemic, don't worry, this is the only nucleus, so you can use this whole space. What happens then is this nucleus gets activated, and that causes you to feel hungry and also thirsty. That is a different way, but it is involved in both. Okay. And the body is waiting for food. The body is waiting for food and it doesn't get the food. What happens then is hypoglycemia will overstimulate this nucleus, causing you to be angry. Overstimulation will occur, causing the person to be angry. Okay. Make sure you draw an angry man here. That is the only nucleus we need to talk about, that you need to know in the tubural region. Now we are going to go into the preoptic region, and this is the most interesting nucleus which we are going to learn today. Okay, so this nucleus, you cannot call it a medial or a lateral because it's in the middle. Okay, and I just call this nucleus the dirty deeds nucleus. Okay, because this is called the preoptic nucleus, and it involves in sexual activity. So this is the nucleus that produces GnRH, gonadotrophin releasing hormone, which causes the anterior pituitary cells to produce FSH and LH. Okay, this is, till now it is pretty boring, but now comes the interesting part. Did you know that they have found out the cause for homosexuality? I told this in the last class that I will discuss this. Okay, there is a nucleus called the dimorphic nucleus. Dimorphic nucleus that determines your sexuality while you're a fetus. Okay, so I'm going to draw it as a dimorphic person. It determines if you're going to be a male if you're going to like males or like females. There's a nucleus called the dimorphic nucleus, which determines if you are going to be attracted to males or females. Okay, this is called the dimorphic nucleus. And what happens is, in straight people, it develops in one way. In homosexuals, it develops in another way. Okay, and that is all because of androgens from mother will cause the development of this. Okay, the androgens from the mother is what determines the if you're going to be born as a gay child or if you're going to be born as a straight child. And there's one very important thing when it comes to clinics. In whatever exam or in whatever situation, if you ever disrespect anyone for their sexuality, you will immediately fail the exam, first thing, and they might even put you under review. Okay, because it is not their fault, it is not a choice, they're born that way. Okay, and you need to understand, straight people are attracted to the opposite gender. They are not going to be attracted to the same gender. But gay people, they will never be attracted to the opposite gender. They are attracted to the same gender. The same way you have feelings for the other gender, they have feelings for the same gender. So this is the cause for that. Okay, and you have seen how gay people talk and act. That is all because of the way they will develop from this point onwards. Now next.
Shan, what about bisexuality? Like there are people who like both the genders.
That is, I would say, more of a choice. Like this is not a choice, but bisexuality, it's mostly a choice. Okay. Okay, what I'm talking about here is, you have seen the okay, the most on TV, you have seen the most gays, right? The way they act, the way they flail their hands and stuff. That's what I'm talking about here. Okay, that is like extreme levels. But then the majority are people you will never know are gay. Okay, it's just there are some who will act more gay. That is developed from birth. Now next, I want to talk about this nucleus is going to be about hunger and thirst. So there must be one more nucleus which is related to satiety. That is, okay, once you are done eating, a nucleus must activate. So that nucleus, I should draw it below. Okay, I will draw that below because it is called the ventromedial. Ventromedial hypothalamic nucleus. Okay, the other one is called the dorsomedial hypothalamic nucleus. Now let me do this one first. So now you're done eating. Okay, and you're now full. Okay, so this nucleus is the nucleus that tells you it's called satiety. Wait, It's called satiety. Okay, these people, once you are done eating, then these nuclei will activate, and then it will tell you to stop eating. If there is damage to this nucleus, these people are always going to feel angry and hungry. Okay, always angry plus hungry, because this nucleus is not working. It doesn't tell I am full, stop eating. And these people will also be obese. Okay, I hope you guys understand this. Now next, the dorsomedial nucleus. It is the nucleus that is involved in feeling angry plus feeling punished. What does that mean? So here's your mother. And she tells no TV. Okay, so that makes you feel angry and it makes you feel punished. So that feeling you get when this nucleus is activated. Okay, so I hope you guys understand this. These are the nucleus of the tuberal region. Next, I'm going to come to the nucleus of the supraoptic region. Guys, this is important for both neurology and for endocrinology. There is one nucleus called the paraventricular nucleus. So guys, there's a nucleus called the paraventricular nucleus, and that produces a hormone called oxytocin. Can someone tell me the functions of oxytocin? Two functions.
It's the feel-good hormone.
It has a function in that, yes. But more than that, it has two very important functions in females.
Contraction of uterus.
Yes, uterine contraction. During pregnancy, when the time for birth is there, has come, causes uterine contraction. One more. Why did I draw this? I hope you guys know what this is.
Production
breast
of
development and milk ejection.
Yes, milk ejection. What is the hormone that causes milk production?
Prolactin.
Yeah. Okay, that is important. So I hope you guys understand this. Next, we have, if you have any doubts, you can ask me, okay? You can unmute and ask me immediately. We have a nucleus that is involved as the internal biological clock. It's called the suprachiasmatic nucleus. We have three nuclei here. Okay, we have one more nuclei here. We have the suprachiasmatic nucleus. Now, the suprachiasmatic nucleus is involved in the internal biological clock. Manages the internal biological clock. Okay, so This regulates. Okay, there are some people who have to have a nap in the afternoon. Okay, wait, scratch that. Let me tell it like this. You know that it is light in the morning and dark at night, and it's a 24-hour cycle. So when it is light out, it causes the pineal body, okay, to suppress its secretion. Pineal body will stop secreting melatonin, and it will cause you to wake up. When it is dark outside, it makes you feel sleepy. Okay, this is connected to pineal body. Okay, guys, what is the nucleus? Don't draw this because you may need the space. Here's the pineal body, and adjacent to that, there are two nuclei which are interconnected. What are these two nuclei called? Here's the pineal body. Here's the third ventricle.
Habenular nuclei.
Habenular nucleus. Habenular. Yes, nice. Okay, now let me explain the function of the habenular nuclei like this. So I hope you guys, okay, so when you go to, let's say, Pizza Hut, let's say you go to Pizza Hut, you're hungry and you order a pizza, and it comes and it tastes delicious. Okay, you feel happy. That is because dopamine is produced in the body. The substantia nigra and other places will produce dopamine. Okay, that makes you feel happy. But let's say the pizza that came does not taste good, then a serotonin analog is produced that is stimulated. Okay, when the pizza doesn't taste good, you feel unhappy. That stimulation is given by the habenular nucleus. It tells the body to produce serotonin, and it makes you feel bad. It feels okay. And then I hope you okay, so this hypothalamus is involved in regulation of temperature. The hypothalamus is involved in regulation of temperature. One side is the AC, the other one is the, sorry, it's not, okay, it wasn't writing. This side is the AC. Here is the AC of the body. Think of it as the AC. It blows out air. Okay, this is called the anterior thalamic nuclei. Okay, this detects if the temperature goes up. If the temperature goes up, it detects it, and it causes activation of sweat glands and causes vasodilation. And just think and tell me, this nucleus has a function to do with the autonomic nervous system. The autonomic nervous system is made out of the sympathetic and the parasympathetic nervous system. Can you tell me, does this nucleus associate with the sympathetic or the parasympathetic?
Sympathetic.
Think again.
Flight or fight response.
Yeah, that will increase the temperature. Our goal here is to decrease the temperature.
Parasympathetic.
Yes. You don't want your body to be activated now. It is also involved in parasympathetic action. Okay, this nucleus is also involved in parasympathetic function, but it is mainly for micturition and defecation. Associate it this way. Remember, the anterior thalamic nucleus is the AC of the body. Okay, when the temperature goes up, it detects it and causes sweat glands to produce more sweat and causes vasodilation to bring the temperature down. It also is helped by the parasympathetic nervous system, which slows down the body. And there are some other parasympathetic nervous system functions, which includes micturition and defecation. Okay. Now the medial nucleus of the mammillary area. Okay. Posterior hypothalamic nucleus. Okay. Give me a second. Okay, posterior hypothalamic nucleus. This is the, it has two functions. It is, the first one is, it's the anti-fall center, that is prevent not you falling, body temperature from going down. Okay, so the two opposite functions. It causes vasoconstriction and shivering. Okay, and this is associated with the sympathetic nervous system. Okay, that can lead to, yeah, you know the functions of the sympathetic nervous system. You guys understand this? These are the nucleus which are related to the nervous system. Okay, because there are other nuclei also, like the supraoptic nucleus, which produces ADH. We won't go into detail. Now, next, I want to talk about some tumors which arise in this area. Okay, guys, read this. So craniopharyngioma is the most common childhood benign. Remember, from pathology, oma is benign. Supratentorial tumor. I will explain that. These are tumors that derive from the rat case pouch remnants. Okay, and due to its location, it can cause compression of the optic chiasma, leading to bitemporal hemianopia. And this is histology. You can see a lot of calcium deposits, and on histology, you get a lot of cholesterol crystals. So what you need to take from this is craniopharyngiomas are the most common childhood benign tumors. Okay, these are tumors that derive from the rat case pouch. Okay, so I told you earlier, here is the rat case pouch, which will migrate upwards. Sometimes during migration, some cells can be left as it is. Okay, you're a child. Now these can grow into a tumor which will cause compression. It will grow like this, and it will cause compression of the optic chiasma. This tumor, it doesn't produce anything. It's just going to be a space lesion. So it will grow and cause compression of the optic chiasma, and it leads to bitemporal hemianopia. Now I'm going to explain what that is. We are going to do that it's a big topic. If you don't understand this, it comes under ophthalmology. Okay, so I need you guys to tell me. I'm going to give you guys some options. Which option is it? Is A, B, B, A? Can you guys tell me which side is affected? Is it the A side or the B?
A.
It's the A side. Okay. And it says bitemporal. So is both sides affected or is it just one side?
Both sides.
Bitemporal,
Both sides.
both sides. Okay. Hemi means half. So does it mean that it is loss of vision in this way or in this way? The first one or the second one?
Second one.
Second one. So remember, these people will have loss of vision bitemporal. Bi is both sides. Temporal means the lateral aspect. Okay, the lateral aspect. Hemianopia. Hemi is half. Anopia is loss of sight. Okay. And let me tell you guys how this can manifest. Read this case here. Just read the case. Read this part. This is how they will present. Okay. Now, that is craniopharyngioma. It is a benign growth, that is a space occupying lesion. The next one are pituitary adenomas. Now, pituitary adenoma is a growth of the pituitary gland of the acidophilic cells. Acidophilic cells. I told you guys there are two types of cells. One is the basophilic and the acidophilic. And the acidophilic cells produce prolactin and growth hormone. Okay. So can someone tell me? Okay. Now I'm just going to draw an image. Here are two cells. Okay. One of these cells is affected by the tumor. This is a tumor cell. This is a pituitary adenoma cell. And this is a normal pituitary cell. Now, our body has a feedback mechanism. Okay, someone has asked me to repeat the craniopharyngioma. I will, okay, let me explain the pituitary adenoma and I'll go back to that. I will compare the two. If you didn't understand, I'll do it again. Okay, so now here is a pituitary adenoma cell. Okay. Do you know how these cells occur? So usually these are monoclonal tumors. That is, a single cell somewhere starts proliferating in a neoplastic way. Okay, it will start dividing like this. Okay, this is how a tumor forms, and this is an adenoma, so it's a benign tumor. But the problem is, can someone tell me what is wrong in this tumor? What does the word adenoma mean?
Fibrous.
Sorry?
Fibrous.
No. It has a different function. The moment you hear the word adenoma, what does it tell you?
Tumor in the gland.
Yes, it's a glandular tumor. It's a glandular tumor. Remember this. Adenomas are glandular tumors. Tumors of glands. So that means it has a secretory function. It has a secretory function, okay? If you haven't, I will send a video I made for our NMU people. But adenomas are tumors which are glandular origin, which has a secretory function. So what happens is normal cells are going to be inhibited by two things. Okay, these are. So can someone tell me the hormone that inhibits prolactin release? The hormone synthesized in the hypothalamus that inhibits prolactin release. Guys, come on, endocrinology. Actually, A levels, high school stuff. Prolactin inhibiting hormone, PIH.
Progesterone.
That's a different cycle. What I'm checking for is progesterone is produced in the ovaries or from the what is it? Placenta. Sorry, that causes. That's a different cycle. I'm talking about the hypothalamus. Do you guys know that prolactin inhibiting hormone? There's a
Dopamine.
Yeah. Dopamine, it is basically dopamine, but because it is produced in the hypothalamus and it inhibits the pituitary cells from producing prolactin, it is called prolactin inhibiting hormone. It is basically dopamine, okay? And what is the hormone that inhibits growth hormone release? Growth hormone inhibiting hormone or somatostatin. Okay, this hormone yeah. So what happens is then there will be a decrease in production of growth hormone and prolactin. Okay, I hope you guys understand this, right? Now the problem with these adenoma cells are they don't care. They just don't care about these. I'm doing basic pathology right now, okay? They don't care about whatever that comes to inhibit it. Don't care. It will just keep producing. So now tell me, what happens if there is excess growth hormone in a child? What is that condition called?
Gigantism.
Yes. What is excess growth hormone in an adult?
Acromegaly.
Acromegaly.
Do you know what happens in those two? Let me just quickly explain. So if there is excess growth hormone in a child, it is called gigantism. Now, when you talk about gigantism, do you know that the bones, what is this area which grows?
Epiphyseal.
Epiphyseal plates. Yeah, these can elongate. So the person will be taller. And because one of the function of growth hormone is it increases lean body mass. It increases lean body mass. So the child will be very tall and very thin. Okay, the child will be very tall and very thin. Okay. Now, if growth hormone, if this tumor, if a pituitary adenoma happens in an adult, what happens is a condition called acromegaly. Now tell me, is this bone able to grow taller now? Can it elongate as an adult?
No.
No, because those epiphyseal plates fuse, and at around the age of 20, you stop growing. Okay, so around the age of 20, you stop growing because those epiphyseal plates have fused. But no one said that the bone can't grow this way. The bone can thicken. So bone thickens, soft tissue increase, and this is best seen in the face. They have huge features. They have a very thick tongue. They have a very thick tongue. Soft tissue. Okay, the facial bones will thicken, and this is an introduction to endocrine system, but this is important when learning pituitary adenomas. And what happens if prolactin increases? Causes give me a second. Causes galactorrhea. Can someone tell me what galactorrhea is? Can someone tell me what is galactorrhea and what is amenorrhea?
Amenorrhea is abnormal absence of menstruation.
Yes.
And galactorrhea is milky discharge from nipple.
Yes, exactly. It's a milky discharge. Okay. So what that means is it's not going to flow. There's not going to be milk flowing. It'll be a discharge. Okay. And this is okay. This is seen in males and females, and obviously this is only seen in females. Okay. I hope you guys know that. Now there was a word here that said supratentorial. Okay, I will explain the differences now. So craniopharyngioma is a tumor that occurs because of cells in the rat case pouch remnants. So these cells are supposed to perfectly go and attach to the developing posterior pituitary and form the anterior pituitary. But on the way, those cells are going to be left behind. Some cells will be left behind. So what happens is, in these children, remember, look at this. It's a childhood tumor. Okay, but adenomas usually occur with age. Look at this. She's a 27-year-old female. Amenorrhea. Okay. Now, in craniopharyngioma, it's a tumor of children in which this remnants will grow and cause compression of the optic chiasma. It is going to cause compression of the optic chiasma. This is the one thing you will see in these tumors. Okay. Okay, it's not the only thing. It's going to cause compression of adjacent structures and everything. But when it comes to case studies, that will be the only thing that will be given, because in posterior pituitary, also you get the bilateral, bitemporal, you can call it bilateral also, hemianopia, because those cells, okay, those cells can also grow and cause the optic chiasma to be pushed. Okay. Did you get the answer? If not, just send me a message. I'll explain it again. So these patients will also have damage to optic chiasma. They will also have bitemporal hemianopia. Okay. So now I will talk about have you heard of structures called the Falx cerebri, Tentorium cerebelli, and Diaphragma Selli? If you haven't heard of these, let me send an image. Wait. There's a very good image here. Herniation syndrome. Okay, look at this image. Now, you might have heard of these words. Don't worry, we will go back and draw this. Falx cerebri, Tentorium cerebelli, and one more. It's called the Diaphragma Selli. Now, what I need you to know is these are dura mater structures. Structures of the dura mater, which will come here between the separation of the two hemispheres, and this structure is called the falx cerebri. Okay, let me recap. All three of these are structures of the dura mater. So the falx cerebri is present in between the two hemispheres, and the reason for this is, the reason there's a structure like this is, it stops the brain moving too much. I told you guys that the brain is present in the subarachnoid space floating. So it can't just be allowed to float as much as it wants. There has to be a limit. This limits it. And the Tentorium cerebelli, the tentorium is here. You can see the structure here. And this is what you call supratentorial area, supratentorial, and this is the infratentorial region. Okay, it's not hard. I hope you guys understand that. There's nothing to memorize there. Then the Diaphragma Selli. So it is basically the Diaphragma Selli. We have the hypothalamus like this. Can someone tell me what is this structure called? The structure to which this falls into? The bony structure?
Cavernous sinus.
No, that is lateral. That is lateral to these. Sellatricica. This is the sellatricica. Yeah, it's like a pouch into which the pituitary falls, and the cavernous sinus is lateral like this. Okay, since you brought it up, I will just tell that cavernous sinus is lateral to the sellatricica. Now the Diaphragma Selli is the dura mater, basically white fibrous tissue that prevents the pituitary from moving around. It holds it and prevents it moving around. Okay, that's a tiny structure. What you need to know mostly is the falx cerebri, and let me draw it like this. It's like a scythe. You know, have you seen pictures of death holding a scythe? It is the same structure. So it is like this. Okay, it comes all the way to the front of the skull, Let me use a different color for the skull. So it comes all the way to the front of the skull and it goes like this. Okay, and over here, this is where you have the sella trishka. So please understand that the falx cerebri will start thin in the front and go all the way to the back of the skull. At the level of the sella trishka, you get the dura mater going like this, and this is what forms the tentorium cerebelli. Okay, the falx cerebri is perpendicular to the tentorium cerebelli. You saw it in the previous diagram, and the tentorium cerebelli is what will divide in cases you will see words like supra tentorium and infra tentorium. Okay, let me just add the diaphragma celli also to this. Here's where you have the diaphragma celli. So those are the dural structures, and supratentorial tumor. Now that is it for hypothalamus. So if you have any questions, you can ask. I'll give a 5-minute break. Today's lecture, it won't take that long. So I'll give a 5 minutes break. We'll start in exactly 5 minutes. So 53, we will start.
Shan,
Yeah.
in eating disorders like anorexia or bulimia nervosa,
Yeah.
won't the lateral or any of the ventromedial hypothalamic nuclei be affected?
Definitely. Okay, it's more of a psychiatric situation. So what happens there is this region of our brain, this region, it will tell, it is involved in thoughts and emotions. Okay, so what happens then is it will tell that you are too fat. Okay, it will tell the anorexia person you're too fat. The way it tells it is, it will keep stimulating the satiety center, saying you're full now.
Oh,
Understand?
okay.
So bulimia patients, it's the opposite. They will be like there's no, okay, bulimia patients can be of two things. One, the satiety center damage. I just told that. So those patients, they will never feel full. They just keep eating. The other one is, it's rare, but people can feel that they're too thin. I got a message from a friend. So guys, we'll start again. I'll give 1 more minute and we'll start again. So can you guys see this diagram? You guys can see this 3D structure, right? Now look at this. Okay, I'm dissecting everything. Look at this from front to back. You can see the Falx structure. Okay, it's white fibrous. It's dura matter, so it's obviously a fibrous structure. And from the bottom, you can see the Tentorium cerebelli. Okay. Now I'm going to dissect these. You can see the Falx going from here. And okay, can someone tell me what is the pink structure? What is this pink structure? Oh, sorry. What is the pink structure which I drew above? Simple name. White matter fiber that goes from either sides.
Cingulate gyrus.
No, that is below. This is the cingulate gyrus. What is the connection between the left and the right side?
Callosum.
Corpus callosum. Okay. This connects the left and the right side. This is especially important when it comes to studying language. Now, you can see the Tentorium cerebelli. So the structures which are above this. So the structures that go above. Why is it not drawing? So the structures that go above this are supratentorial. And below that is infratentorial. Okay. There's one more image I found. Here is the sella trushica, end of the brainstem. Let me quickly draw the structures again. Here's where the brainstem ends. Here's where the third ventricle goes. And here's where the hypothalamus descends into the sella trushica. Okay. And that's where you get the diaphragma celli also. And the blood vessels are all there in this region of the bone. Now back to the lesson. Now we are going to learn about language. And this is a very interesting topic because okay, let's go into this. I'll explain why it's interesting. So first of all, can someone tell me which hemisphere is involved in language? The dominant hemisphere. Left or the
Right
right?
hemisphere.
In majority,
Right.
it is the left hemisphere is involved in language. Okay. The left hemisphere. If you're a right, okay. The left hemisphere is where you have the language centers in majority of the people. But there are some people in which the right hemisphere can have it. And are they left-handed people or are they right-handed people? If they are, okay, wait. If their left hemisphere is dominant, are they left-handed people or are they right-handed people? First question.
Right.
Right-handed people.
Yes. I told you guys, cerebellum and the sympathetic nervous system are the only ones which are ipsilateral. The cerebrum, it is always contralateral. So the left hemisphere has the language center, but its function is going to be on the right side. So right-handed people, all of them have left dominant hemispheres. There are some left-handed people who have right hemisphere dominance, but even then a majority are left hemisphere dominance. So think of it like this. I always consider myself to be a person whose left hemisphere is dominant. Okay, I always consider myself because my creativity is not as good as my logical thinking and stuff. So I'm more of a logical thinker, not a creative person. So logical stuff, calculating, language, all of these, they are left hemisphere functions. And you can, I remember it like this. These people, they are out of this world. They don't know what is happening. They are very wise, but they don't know what is happening. And a good example is the famous 5 character, George's father, Mr. Quentin. So he's just a person who has left hemisphere working. The right hemisphere is involved in creativity, emotions. So this should tell you guys more about me. Geometrical figures and internal external orientation. What does this mean? Let's say this person who has damage to the right hemisphere, these people, if you put them in a familiar place, okay, you take them and go and drop them just outside the house, near the shop which is outside, which is very close to your house. They still get lost. These are the creative people. Okay. Now, there is a condition called dysprosody. Dysprosody. Have you guys watched The Big Bang Theory? He doesn't understand sarcasm. Okay. He doesn't understand people's emotions. There are people who do not understand expressions or emotions, and that is called dysprosody. Okay. If you didn't understand anything till now, just ask. And these people are unable to express emotions. So think of it like this. These people, dysprosody means a lack of understanding and a lack of expressing emotions. Okay. These people have a lack of understanding and lack of expression of emotions. So if you guys have watched the TV show Friends, you can remember there is an episode where he teaches his friend in a very monotone way. That is because his right hemisphere was not working at that time. Only his left one was. Okay. When it comes to doing something, when it comes to teaching, if the person teaches in a very, how do you say, monotone way, it gets boring real fast. But when there's expression, when there's passion for teaching, that comes from the right hemisphere. Okay. The right hemisphere puts creativity, emotions into your speech. Okay. That is the function of the right hemisphere. Now, there's one important thing. Why is it easier for a child to learn a second language, but why is it more difficult for an adult to learn? So, okay, this is just a personal thing, but one day when I have a child, I'm going to teach that child several languages. I'm going to, as a child itself, I will start teaching a lot of languages because that will retain longer. These children, they have developing brains. Children have developing brains. Okay, so when the child learns a new language, it will be associated. So there's a primary language and the secondary language, both in the same area. Okay, but as an adult, and remember, okay, I'll come to that. In adults, the primary language will be in one area, and the secondary language, which they will learn as an adult, is in a newly formed area. And this is a difficult process. This is very difficult to do. Okay, so this is why children can easily learn and retain a language, and also the reason why these children will develop the native accent very quickly. You guys know that, okay, the British accent, if you go as an adult, it'll take, let's say, a long time for you to get that accent, but your child, let's say he's a 2-year-old, he will start talking with that accent itself. Okay, because it will be associated with the same area. Now, do you guys understand this? If you want, I can explain this again. If not, I will go into the language pathways. Okay, so the language pathways, it has to be a combination of sensory input, processing, and output. Okay, this is basic knowledge. There has to be a sensory input, processing, and output. So for the language also, it's the same thing. Let me draw the brain like this. Now, so let's say this is a person's eye. I can't draw the ears, so we'll just leave that. Just draw this with me. Now I'm just drawing the airway. What I'm drawing right now is the airway. Is the hyoid bone. It goes to the lungs. Now look at this. Here are the lips, the muscles of the lips. We have the pharynx. Then we have the larynx. And we have the lungs. Okay. We have the soft palate. Okay, soft palate. All these structures, actually, sorry, guys, this comes here. Sorry, soft palate, all of these. Now, let's say there is sensory information coming from your eyes. Light will come. It will go across to the primary visual area. This is called the primary visual area. Why do you call that a primary area? Because it receives the information. It receives data. It receives data. Okay. And adjacent to that, you have the association areas, which processes the information. Okay. Guys, these are very important when we come to ophthalmology. So try to understand this. So this is the primary visual area, which gets an image like this. It gets, you guys know computing, right? You have seen what pixels are, right? So it will get pixels. It will just get pixels like this. Okay. And next, we have the visual analysis area. That pieces the pixel together to make the word. Okay. Let me. Wait, guys. Wait, let me draw a different set of pixels. So this will piece it together as Peter. Okay. Now what happens if a second signal comes? So there are people who are not studying in China. So for you guys, this should look very weird. For those who have not studied in China, they may not know what this is. Okay. And this is called the visual recognition. It tells that the letters are P, E, T, E, R. And it tells you, remember this is a visual input. So what happens is the visual recognition speaks it out. Speaks it out for Wernicke's area to here. Just write it like this. What happens is the visual recognition area, it speaks it out. It's going to say P, E, T, E, R. And the other one, it's going to be told as knee. Okay. So those signals will go into the Wernicke's area. Oh, sorry. This is the Wernicke's area. Okay. And I need you guys to know this region is the dictionary of our body. There's a dictionary. Here's the Wernicke's area. Okay. So what happens is the visual recognition will speak it out for the dictionary to hear. Okay. And that is going to know that it was a name that came. Peter is a name. It is going to know that. And ni is, it means you. Okay. So the dictionary is going to know that. And now this is the visual input. Let's talk about the auditory input. See, the thing is, I can't draw ears. So I'll just draw the ears outside. Okay, no, I'll just draw it here. Now the ears will send its signals to the primary auditory area that goes to the association areas and to the tertiary areas. Primary, secondary. These are basically the association areas. And that will visually tell. It will visually tell. So let's say you hear the word rose. It is going to show a picture of the rose to this area. Okay, it is going to visually tell it to the Wernicke's area. That too, the area doesn't matter. I just wanted to tell you that there's a dictionary here. Okay, because there can be damage to this dictionary. We will discuss that. Now, everything is fine. This is where language comprehension occurs. Wernicke's area is involved in language comprehension. It understands what is told visually using visual language, written language, so there's different types of languages. Body language, from auditory. So whatever input that comes, it could be visual. You know, people who can't speak, who are deaf, they still understand language. They understand this. Then written language, everything comes from your visual area to the Wernicke's area. And then there's the body language. It tells you about a person's actions. A girl flipping the hair. It will cause Wernicke's area to send signals to the relevant area saying that girl is attracted to you. Okay, and then the auditory, what you hear. So the best way to, okay, this is something when it comes to learning, but when it comes to learning, if you can combine more than one of these, if you can combine visual with auditory, you will have a better comprehension. That is basically a live lecture. Okay, what we are doing right now, it includes both visual and auditory. But if you go and read a book, that is just visual language. That will not retain longer. You won't understand as much. Okay. And now these signals must go to different areas. But it first and most importantly must go to the Broca's area. Guys, I need you to understand the importance of this structure. What is this structure? What is this structure called?
Central sulcus.
Yes, it's the central sulcus. Why is it important? Because remember this, right next to the Broca's area is going to be your mouth, your face, your upper body. Okay, and that means when Broca's area is stimulated, it will send motor signals to your mouth, all of those areas. Okay, and if there's damage to the Broca's area, it is more likely you will have damage to the upper limbs also and your speech. Do you guys understand till now? If you don't understand something, you can ask. Okay. Now, there are fibers. There has to be a connection between these two, right? These fibers which connect each other are called the arcuate fasciculus. Fasciculus. Okay. I'm going to ask a question just to see how much you have understood. Is the Broca's area involved in language production, in speech, or is it the Wernicke's area? Which area is involved in language production, speech?
Broca's.
Yes.
Broca's.
Yes, because it is in the primary motor cortex. It is in the motor cortex. This area is the motor area. This is the sensory area. Okay. So it should tell you Wernicke's is just sensory. Broca's is motor. Now what happens is the Broca's is going to get other fibers. I cannot draw it here, but basically it's going to get fibers from, guys, the thalamus, the basal ganglia, they are at the bottom. They are in this region, but because of the space, I will be drawing it from the top. They will receive input from cerebellum. Sorry, guys. Okay, they will get input from the cerebellum. They will get input from the thalamus. They will get input from the basal ganglia. I told you guys this in the same in the last lecture about cerebellum. Okay, the Broca's area will also get information from these areas. Okay, and they will send signals. They will send signals to cranial nerve 7. Wait, 7, 8, 9. No, sorry. Yeah. So they will send signals to cranial nerve 7, which will innervate the lips. Okay. They will also send signals to cranial nerves 11. Okay. 10, 11. Cranial nerve 10 and cranial nerve 11. Okay. 11, pharynx. This soft palate. And cranial nerve 12. You haven't learned this yet, but I need you to remember cranial nerve 12 is found medial to cranial nerves 10 and 11. Even okay, draw it below. It doesn't matter, but it is below these things, but it is medial. Okay. This sends it to tongue. Okay. And that causes the mouth to move producing, that is going to coordinate the movement. Okay, and there's a very important coordinator, the cerebellum. I told you guys last lecture. Can you tell me what will happen if there is incoordination in these areas? What is that condition called? If there is no proper coordination, there's only two. Yes, there's going to be ataxia. So the lips don't know how to properly speak the words. It'll either overspeak. It'll let's say a lisp. Lisp is not caused by this, but it can cause something like a lisp. They're speaking and they're still not done with speaking, or what they say, it doesn't make any sense. Okay, remember, cerebellar input is very important. I discussed that last time. It is going to affect the same. Okay, now this is the basic pathway. If you guys didn't understand this, you can ask, because I'm going to go into the disorders. We need like not an hour. We'll quickly go through these. Nothing much. Now, the first one is a disorder called dysphonia. Okay, that is difficulty in producing sound. You can read this case. Look at this: sufficient volume or cannot maintain a conversation longer than a few words. Now, what happens here is, tell me this: do you speak during inspiration when you inspire, or do you speak when you expire?
Expire.
Yes, you speak when you expire. Okay, try to speak while you're inspiring, you cannot. Now what happens here is, air is going to go to the lungs. And then so what happens then is, the vocal cords are present close to each other. These are the vocal cords. Okay. Air is, oh sorry, during inspiration. So air is going to the lungs during inspiration, and the vocal cords are close to each other. So what happens when the air exits during expiration? What happens is, there's going to be a turbulent flow. The turbulent flow through these vocal cords cause it to resonate, generating sound. Okay. So the air will flow in a turbulent way. Generating sound. And what helps coordinate and tell you what to say? What helps the lips and everything to move in a coordinated way? Lips, even these are innervated. It is by those cranial nerves with the input of the cerebellum and the other structures. Okay, cerebellum, basal ganglia, and the thalamus. That tells these vocal cords exactly how to move. Now, our issue here is in two areas. In dysphonia, phonation. Okay, when it comes to phonation, so what is phonation? Is generation of sound. When you add the word dys, it means there is a disorder in generation of sound. Okay, what happens here is, in dysphonia, there's a problem of the mainly the main damage is going to be in the lungs. So when the lungs are not producing enough force to push the air out, you don't generate sound. I hope you understand that. Lungs are not producing enough. The volume is not high enough. Then it could be a problem in the larynx and its innervation from okay. Here's where the problems are. So the first problem is production of sound. The next problem is converting that sound into meaningful words. Okay. So she can produce sound. She can scream, she can produce sound, but it's like she's speaking a foreign language and words from her own is added to it. It's like, you guys know what Singlish is, right? Sinhala and English combined. So for a person who knows only English, it'll be like listening to a patient who has dysarthria. Okay. I hope you guys understand that. Now, there's a lot of causes of dysarthria, but basically it could be damaged due to the pyramidal extrapyramidal. Just to check something, I didn't talk about this much, but do you know what are pyramidal pathways and extrapyramidal pathways? Can someone tell me what is the pyramidal pathway?
Corticospinal.
Yes. What is the extrapyramidal? Okay, the corticospinal. What is its function? So the corticospinal tract is involved in voluntary muscle movement. Give me a second. So the pyramidal pathway, it is involved in voluntary muscle movement. Okay. And then the extrapyramidal, and this is based, okay, the voluntary muscle movement, this is basically the corticospinal tract. And the extrapyramidal, it is involved in involuntary muscle movement. So the rubrospinal tract, which originates from the red nucleus, all those tracts, they are part of the extrapyramidal. They are involved in involuntary muscle movement. Okay, we will go into detail later. Those two together are called pseudobulbar. Then defects in the cerebellum. I told you guys, ataxia is basically the final position of the muscle is not known. In simple words, it will not be able to properly produce and finish the word. Neuronal bulba, neuromuscular diseases. In our next topic, we will talk about this. Myasthenia gravis and Lambert-Eaton syndrome or muscular diseases. If you have problems in the muscles, if you have a swollen lip, can you speak properly? Do you guys understand this? Muscular myopathies, it's simple. A disease of muscles. If you have swollen lips, you can't speak properly. Okay. So yeah, that is it for that. Guys, do you need me to draw any diagram for articulation? Or is that explanation okay? So, okay, got it. Next, we'll talk about aphasias. Okay. Now, give me a second. So yeah, now let's talk about aphasias. Aphasia is the meaning of that is impairment of language, and it occurs due to defects in two areas, either production or comprehension. Can someone tell me production is by which area? What is the language center for production? Broca's. Comprehension? Wernicke's. So production, it is basically the expression, and the Wernicke's is basically the reception. Okay, now you can see the two topics here. Expressive aphasia. So let's draw the brain like this. Guys, I cannot highlight how important this line is for stroke, for motor, even for language. This line is the most important line. Okay, divides the motor and the sensory. It tells you where the lesion is in a stroke, and it tells you where the Broca's area is. Is the Wernicke's area. What are these fibers called? What are these fibers called?
Arcuate fasciculus.
Yes. Okay. We don't need that, but this is the structure. Okay. Now, expressive aphasia is damage to the Broca's area. Okay. It is damage to the Broca's area. So what happens then? Can't speak out. Okay. It's called non-fluent aphasia. So he can't speak out. Can he repeat what is said? You tell him, okay, repeat this. Can he repeat it? No. Do you guys remember a syndrome called locked-in syndrome? Do not think this is a cause of that. Do you guys remember a syndrome called locked-in syndrome? Can someone tell me what happens there? Can someone tell me what happens in locked-in syndrome? This is under coma. We did this. As the name says, what does a patient who has locked-in syndrome exhibit? So, okay.
The patient can't move, but he can sense everything going on.
Yes, he knows what is happening. Think of a coma patient who knows what is happening. He knows everything that is happening around him, but he can't express himself. Okay, the only thing he can do is he can move his eyes around. He can blink and move his eyes around. Okay, so it's like this. He's basically, he understands everything. It's like a patient in locked-in syndrome, but don't confuse these. Locked-in syndrome is a type of coma. The patient can't move his body at all. In this, he's fine, but he's the thing that is common in this is he's able to understand everything, but can't speak out. Okay, he's able to understand everything that is told, but he can't speak out. So he's called a mute. The word for it is he's a mute. Okay, do not assume that these are logged in syndrome patients. Write it down in your own words. It is he's a normal person. It's just that he seems to be like that. So this is normal. That means he can read, hear, see well. Okay, sorry, read and hear well. Okay, and in his mind, he can tell the correct words. Let's say you ask him hi. In his mind, he will be like hi. He will tell the correct word. Okay, in his mind, he will be like hi, but he just cannot express it. Do you guys understand this? Next, we are going to draw this again. Broca's area. Wernicke's area. Association fibers. Now, the damage is this in this area. Okay. So let's take the normal structure now. First, they speak a lot, but selects wrong words. Okay. It's like in Sinhala, there's a saying, "Yanne koheda malle pol." Same thing happens here. You ask, "Where are you going?" He replies, "My bag is full of coconuts." Okay, because there's damage here, so these people can't understand what people say to them. Okay. Now, let me explain this again. So in receptive aphasia, these patients, they're speaking. They are speaking, but they don't know what they're speaking. Okay. They in their mind, they think they're going to say, that is a beautiful rose. In their mind, this is what they want to say. Remember, it's ours, this area which tells you what to say. Okay, this area tells you what to say. It sends signals here, and it takes the words from the dictionary and sends those words to the Broca's area, and that's what speaks it. Okay, that's what I meant by mind. But what the person actually says is, do you guys understand this? Okay, and this is a very sad situation. They speak a lot. Okay, you can't shut them up. They keep speaking, but they don't know what they're speaking. They don't understand that what they say is wrong. Okay. Also, can these people repeat what is said? Can these people repeat what is said?
No.
No. Okay. There's actually around 11 types of aphasia, but then the most important ones are these 4. Okay. These 4. That's why I'm going to do those. Can't repeat what is said. Okay. There are types in which the person can repeat, but then you have to study to be a neurologist to learn that, or you should be specializing in language disorders. Global aphasia. Can someone tell me what is global aphasia from the word? Which structure is damaged?
Both.
Yes. Both structures are now damaged. Now, can they speak? Can they speak? No.
No.
Can they comprehend what is told?
No.
Okay. That is that. Now, nominal, from the word itself, what you need to know is it means name. Okay. Nominal is names. This is a disorder in which there's a problem in the dictionary. I told you guys there's a dictionary in this area. So this dictionary is what is damaged. Okay. What happens is you show the person a book. Let's say you show this person a book and ask, what is this? Okay. And the person will say, it's a car. He knows it's a book. He knows the function of the book. He knows everything about the book. But then the word is going to be that comes out from the dictionary is wrong. Okay. He knows car and book. That's it. So I hope you guys understand these.
Shan,
Yeah.
patients having global aphasia, so they can't speak, they can't comprehend. So are they considered to be like having dementia?
You can call them deaf and dumb. You can call them. What was the word? I didn't hear. What was the word you said?
Dementia. Dementia.
Okay, dementia is a different situation. That's actually a very good question, because while I was searching for questions, there was one question that people would have confused with aphasia and that. I'll send that case after this class. That's a very good question.
Okay.
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 Guys, remember, most common cause of damage for these are strokes. Can you guys tell me which artery is damaged?
MCA.
MCA. Okay. It can't be hard because we have done the arteries and everything several times now. Now, Alexia, there's nothing to go into detail. These patients cannot read. Alexia, it's something you just need to memorize. These patients cannot read. That means they cannot comprehend the meaning of words. So what that means is you give them a sentence. Okay. you give them a sentence and you ask them to explain it. You give them fox is red. This is the sentence which they have to read. Okay, and you ask them to explain what is said. So when they read, they will keep reading, but it will never register in their head that it is talking about a fox who is red. So what happens is they can't understand those words. Guys, I can't explain this right now, but there's a neurological disorder called dyslexia, which is very similar to this. Okay, dyslexia. Okay, dyslexia patients have alexia, where these patients, they cannot read and understand those words. Okay, dyslexia is a psychiatric condition. Now, agraphia. These patients cannot write to express their ideas. Okay, there are people who can talk fine, hear fine, but they can't write it. They just can't write it. You can talk, have a conversation with them, but the moment you tell, write that down in words, they just can't. Okay, those words are not coming together to form the sentence in that person's mind. Okay, so that is okay. Our lecture is actually done, but I want to discuss this case which I sent once. It is a tumor called pinealoma. Before that, if you guys have any questions, you can ask me from these topics. Did you guys understand? If you didn't, please ask me questions. Okay.
Shan, in Alexia,
sorry?
Can the person in Alexia, can the person read?
In Alexia?
Yeah.
Actually, they cannot. It's just...
They cannot read and understand.
Yeah. Think of it like this. Okay, let me explain it like this. So, normal person can read this as hello. Okay, a person who knows English will be able to read it as hello. Okay, an Alexia patient will see hello, but he cannot read that because his mind has a different setup. It's a language which only they know, only their brain knows. Okay, let me explain this again. So think of it like this. A normal person can read this word hello. It is in English. They know that.
There's actually a Hindi movie on this.
Can you tell the name? Because some people might have watched it.
Tare Zameen Par. Tare Zameen Par.
Okay, that's a very...
Amir Khan's movie.
So I haven't watched it, but if you guys can check it out, you will understand what it is. Because I think that's about a dyslexia patient, probably, most probably. I'm not sure. I don't know.
It's about a kid who can read but can't comprehend.
Yeah. Same thing here. Their brain is wired for a different language which is not in existence. Like the world doesn't know that language. Okay, so when they are shown English, they don't know it. Okay, so for the people who are not from China, who are not studying in China, they should see this as an Alexia situation. They don't know what it is. They can't comprehend what this is. Okay. So there are different degrees of damage. Any other question?
Shan, when you said broadcast patients are mute,
Yeah.
it doesn't mean that they can't produce sound, right? Like they can produce sound, but not a proper word.
Okay. There are different degrees. The worst situation is mute. They are mute. They can't produce any word at all, or they can speak a few words. I didn't explain that well, but basically there are different degrees. So let me explain this. Now, what happens is, do you guys remember the basal ganglia? I told you guys that has the program. In the basal ganglia, it has the program for the motor movement. Let's say our brain tells the basal ganglia, move your leg. The basal ganglia will load the program into the primary motor cortex. Okay. In this situation, it's the same thing. Our brain, these areas will tell, say the word pen. Okay. Our brain, the higher centers will say the word pen. And then the Broca's area must load the program. It must tell, this is how you move your muscles to say the word pen. Okay. If it can be different degrees of damage. If there is minimal damage, he will be like per. He will be able to say something. But if there is extreme damage, he can't speak at all. Do you guys understand that? If you have any other questions, ask.
Sorry, can I ask, global aphasia, is it deaf and dumb or deaf and mute?
Actually, these patients are not deaf. They can read and hear properly. They are mute. Even for this, even though I said deaf and dumb, they are not deaf. But they just can't comprehend what is comprehend things. What is written, what is spoken to them, what is seen. They just can't comprehend that, and they can't put it into words. Okay. Did you understand? I used some how it is. Okay, let's go into the questions. If you have any other questions, you can ask me. So the pineal gland tumor, this CT scan. Can someone tell me what is this area? What is A? You can see. Someone tell me.
Pituitary.
Pituitary. Yes. Pituitary hypothalamus area. Okay. Now, what is B? Okay, this is a bit hard, but this is the thalamus. I got some question. But I have some questions. I'll reply to those. This is the thalamus actually. It is a bit superior to the hypothalamus. Okay. What is C? What is the organ which is present here? So let me help you guys. This is the third ventricle. Yeah, this is the third ventricle. Okay. From here, the third ventricle originates. This whole area. This is the pineal body. What is this? What is the brain stem structure which is present here? Come on, it's the midbrain. Okay.
Brain.
Okay, I have a question about Tourette syndrome. Tourette syndrome is a disorder of, it's a motor disorder. There can be dysfunction of Broca's area, therefore. Okay. So it's called tics. They have vocal tics that can be due to sudden activation of the Broca's area to say something. That's a very good question. But that's a research level question, which I will also find an article and send to the group. Okay, Tourette syndrome. I did this for Parkinson's. I didn't go into detail about these, but I explained what Tourette syndrome is in Parkinson's. And there's a famous YouTuber called Lele Pons who suffers from Tourette syndrome. Let me send the word to everyone. Can someone tell me what is E?
Pons.
Yes. And what is this? Just tell me what type of structure is this? You don't need to tell me what the structure is. Is this soft tissue or something else?
Pons.
It's bone, okay? What is this?
Medulla.
Yes, and what is this?
Cerebellum.
Yes. Now, I'm going to teach you guys something to help you read CT scans. You guys can see that the CSF, the fluid in this is dark. Okay. So that means, is this a T1 or T2 imaging? In which one do you see dark? Okay, you guys check it up, look it up. But what I need you to understand is this white structure is bone, or if it is present, let's say in the brain, it could be calcium. Okay. Now tell me, if there was bleeding, here, would this area appear dark in this MRI, or would it appear light? Would it appear to be dark if there was bleeding?
Dark.
It will appear to be dark. Okay. You will not see the normal brain anatomy. You will see a lot of dark areas like this. Okay. And if there was calcification, you will see it as white areas like this. Okay. There's a condition called cysticercosis. CRCOSIS. Okay. So in cysticercosis or calcium deposits, you can see white areas like this. This is just some hints. Can someone tell me what this structure is? What is this structure? Okay, let me make it easier. No, it's a sheet of white matter which goes to either side.
Corpus callosum.
Corpus callosum.
Yes, it's the corpus callosum. Okay, I'm teaching you guys to read MRI and CT scans. And let me just give you the answer for this, because if you guys don't look it up, in T1 weighted imaging, you will get, okay, wrong color. So if you have a T1 weighted imaging MRI, liquid is dark. T2, liquid is white. Okay, this is for the people who have studied radiology. It's just a reminder of those two. Now, look at this case. 4-year-old boy comes to the ER because of facial hair growth, enlarged genitalia, pubic hair growth. Okay, what are these symptoms? What are these symptoms which I just underlined? What is that indicative of? Guys, I just need to...
Adolescent.
Sorry. Okay, this patient has undergone
increased testosterone.
Wait. Before that, let me tell you, this patient has undergone puberty. Yes, it is due to increased testosterone and other hormones at an age which is 4 years old. What do you call this condition? What is puberty at an early onset? Puberty of early onset. It's called precocious puberty. Okay, early onset puberty. And this patient has impaired upward gaze. Okay, impaired upward gaze. I will come to that. Now, the moment you see these two symptoms, mainly puberty of early onset, you have to understand it is because of a pineal gland tumor, which is called, what is the name of a pineal gland tumor? Okay, the name is there. It is a glandular tumor.
Adenoma.
What is the substance produced by the pineal gland?
Melatonin.
Yes.
Melody.
So if you haven't learned, melatonin brings about changes at the correct age. One function, and the way it does it is through the sleep-wake cycles. Okay. Now, so this patient also has vertical gaze palsy. What has happened here is guys, do you remember I talked about two structures here like this? What are the two structures? In the beginning of the lecture, I mentioned them.
Lateral medial colliculus.
Oh, that is here. That is in relation to the thalamus. What is the structure on the midbrain, which comes out from behind as two humps?
Superior and inferior calculus.
Yes.
Colliculus.
Yes, superior and the inferior colliculus. Like the geniculate bodies, the superior colliculus is involved in vision, and the inferior colliculus is involved in sound, in auditory system. Okay, so now the tumor is in this area. Guys, don't worry, I did this in the first lecture, that is spinal cord, but I will do it again in the next topic, which is going to be the cranial nerves. Okay, that's a big topic which I'm taking a long time to prepare for. So when there's damage to the superior colliculus, it can lead to vertical gaze palsy. Okay. Don't worry. Once I do the topic on ophthalmology, these stuff will be really easy. You don't have to memorize anything. So yeah. Okay. The next one. Can someone tell me the answer? Can someone tell me the answer for this question? I gave you guys a hint also. At the beginning of the lecture, I told, okay, I haven't put that option. It's hippocampus. Sorry, my fault. Okay. The hippocampus is what's most likely to be affected. Sorry, that is my fault. And this is the watershed areas we talked about. A stroke. The patient develops right-sided weakness and numbness, with his arm more severely affected than his legs. He understands everything that is said to him, but he cannot speak. Can someone tell me the answer? This cannot be hard. Sorry? Send it in the group, guys. Send it. I hear you. Can you guys send me the answer in the chat? I just want to see how much you have understood. If possible, send it to me privately. Okay, so from the answers I got, the answer is C. Yes, it is correct. Okay, it is correct. Answer C. Remember, I told you, cerebrum is always contralateral innervation. So the patient has right-sided weakness. Remember the colliculus? I have shown this in different ways. Remember the colliculus, which I have, the homunculus, sorry, the homunculus structure. So the patient has a problem like this. Okay, he has right-sided weakness. Arms more severely. Affected, and he has speech problems. So this is the MCA. I told you guys, this region is the ACA. Okay, MCA. And the PCA. Guys, this question is a question which there were 78% who got the answer wrong. In this question, the source I took, there were 78% who got that answer wrong. Just imagine. This is all basics. Okay. So actually, but the answers you guys sent, it was correct. Okay. So there was a question. There are some questions in the chat which I must go to. There was a question, craniopharyngioma has no secretions. The question was, is that correct? has no secretions. You can write this down. Okay, craniopharyngioma has no secretions. It's just a space occupying lesion which is going to go and cause problems mainly in the optic chiasma. The other question was, for a left-handed person, is it the reverse of what we studied? The only thing that is different is the Broca's area and the Wernicke's area is on the right side. Wait. I told you guys, all right-handed people, they have their Broca's and the Wernicke's on the left hemisphere. Left-handed people, majority, have the Broca's area on the left hemisphere. Some of them have the Broca's and the Wernicke's area on the right hemisphere. Okay. If you guys have any other questions, you can ask. So that's it for today's lecture.